Hey, you're with Book Podcasters. And today we're diving into a topic that, yeah, it can feel pretty heavy, a bit like a lead weight in your stomach sometimes, especially if you're, studying or working in mental health nursing.
Definitely.
But think of this like less of a lecture, maybe more like we're your study buddies here, huddled up, giant coffees, trying to make sense of it all.
Yeah.
Because nursing school, right, sometimes it feels like your brain hit max capacity about, what, 3 chapters ago?
Oh, I hear that. It's a lot.
It is. But we're going to try and break down something really, really important today in a way that hopefully feels, I don't know, manageable.
Exactly. We're getting into Chapter 16 of Townsend and Morgan's Psychiatric Mental Health Nursing, the 10th edition. It's all about understanding suicide risk and the absolutely critical role that nursing care plays. It's a tough area, no question, but
Yeah.
the goal here is really to pull out those key concepts, make the risk factors and the warning signs really crystal clear, and understand what interventions actually work. We want you to leave feeling, more confident, less like you're just drowning in info.
Okay, so first things first.
Mm,
When we talk about suicide, what are we actually, defining here? Let's nail that down.
right. So, simply put, suicide is the intentional act of ending one's own life. And this is a really, really important point. It's not a diagnosis itself.
Okay.
It's a behavior that can be linked to a whole range of things. Psychological stuff, social factors, maybe even some biological or environmental triggers play a part.
And Townsend has this line that really hits home, describing it as a permanent solution to what feels like just endless, inescapable pain for that person in that moment. Wow, that's heavy.
It really is. It puts you in that headspace. And to illustrate this, the book gives the example of Carlos. He's a 22-year-old college student, found unresponsive sedatives and alcohol involved, and there were clear stressors, right? Failed an exam, lost his scholarship. He'd even told people he felt hopeless. But then, and this is key, his roommate said just the day before, Carlos seemed fine, even laughing things off.
Whoa, okay, so this is where it gets tricky because that sudden shift, right? That apparent calm after being really down,
Yeah.
that's not always a good sign, is it?
Yeah.
That could actually be a huge red flag.
Exactly. That's the clinical insight here. That sudden calm, that unexpected peace can sometimes, tragically, mean the person has made the decision to end their life. They found a sort of resolution.
Oh, wow.
Yeah. It's a stark reminder that, someone's outward appearance, how they seem on the surface, doesn't always tell the whole story.
Definitely not.
Yeah.
Okay, so we understand the definition and that really concerning point about sudden calm. What about the things that make someone more vulnerable? Let's talk risk factors.
Okay, risk factors. So think of these as things that increase the likelihood of suicide, but, and this is crucial, they don't directly cause it.
Right, not a guarantee.
Not at all. It's more like pieces of a really complex puzzle. Some key ones. Psychiatric disorders are a big one,
Right.
especially things like major depression, bipolar disorder, schizophrenia. Those significantly elevate risk. Substance use is another major factor.
That makes sense. Dealing with those conditions or substance use, it just makes coping so much harder. What about like life experiences, past stuff?
Absolutely. A history of trauma or abuse.
Yeah.
That can leave really deep wounds and increase vulnerability. Physical health plays a role too.
Yeah.
Chronic illness, persistent pain. That can be incredibly wearing, mentally and physically, contributing to hopelessness.
Mm-hmm.
A family history of suicide is also a recognized risk factor, and sadly, if someone has attempted suicide before, that significantly increases their risk for future attempts.
Okay.
And finally, social factors matter a lot. Feeling isolated, experiencing a major loss like a death or a relationship ending, those can be huge contributors.
And Townsend really drives home that link between mental health and suicide risk, doesn't it?
Oh, yeah. The statistic they cite is pretty stark. About 90% of individuals who die by suicide had a diagnosable mental disorder at the time of their death.
90%. Wow.
It really underlines how vital addressing mental health issues is.
And we see this play out in that other case example, Anna. The 48-year-old woman, she has fibromyalgia, chronic pain, and she starts saying things like, she feels like a burden, or they'd be better off without me. Kind of vague, maybe offhand comments.
Exactly.
But those aren't just throwaway lines, are they? They need attention.
Absolutely not. Those kinds of statements, even if they seem vague or like someone's just having a bad day, they should always, always raise a flag. They can be subtle indicators of suicidal thinking or a deep sense of worthlessness that really needs to be explored carefully.
Okay, so those are the risks. But on the flip side, what about things that can protect someone? The the buffers against this.
Right, protective factors. These are the elements in someone's life that can make it less likely they'll consider or attempt suicide. Things like having strong personal relationships, good connections with family, friends, community.
That social support network.
Crucial. Also, having access to good mental health care, that's a huge one. For some people, spiritual or religious beliefs can provide a real sense of purpose and support.
And it's not just external things, right?
Yeah.
It's also about their own internal resources,
Mhm.
like how they cope.
Precisely. Things like having effective problem-solving skills, healthy ways of managing stress, coping mechanisms that work for them, and importantly, a sense of purpose, some hope for the future. These can be really powerful.
So when we're working with someone, it sounds like a big part of it is trying to identify and maybe even strengthen those protective factors,
Yeah.
help them tap into what's already working.
Absolutely. The book points out that in therapy or even in nursing interactions, it's so important to reinforce their sense of meaning, help them build or rebuild connections, and constantly remind them of their inherent value as a person.
Okay, it makes sense. Now, the really immediate question, how do we spot when someone might be in danger right now? Those warning signs. And there's that acronym, right? Is path warm?
Yes, is path warm. It's from the American Association of Suicidology, and it's a really helpful mnemonic, a tool for remembering key warning signs. Should we break it down?
Yeah, let's do it. What's the I?
I is for ideation. So this is thinking about, talking about, or wishing for death or suicide.
Okay.
S is substance abuse, specifically an increase in use or maybe starting to use alcohol or drugs when they didn't before. P is purposelessness, feeling like there's no reason to live, no point to anything.
Got it. ISP. What's next?
A is anxiety, feeling agitated, restless, unable to sleep, or maybe sleeping all the time. T is trapped, that awful feeling like there's no way out of their situation, like they're cornered. H is hopelessness, a really deep-seated belief that things are terrible now and they're never going to get better.
It sounds crushing.
Is.
Hmm.
Then W is withdrawal, pulling away from friends, family, usual activities, isolating themselves. The second A stands for anger. Increased irritability, rage, maybe seeking revenge. R is recklessness, engaging in risky behaviors without thinking about the consequences. Driving too fast, unsafe sex, spending sprees. And finally, M is mood changes, dramatic shifts in mood up or down.
Wow. That covers a lot. Is path warm?
Yeah.
That's really useful. And, even something that might seem less direct, like in the example where the patient says, sometimes I wish I wouldn't wake up. That still counts, right? That's serious.
Absolutely. That's considered passive suicidal ideation.
Right.
They aren't saying they have a plan, but the desire not to exist is there. And that absolutely requires intervention and further assessment. It's a clear warning sign.
Okay. So we use eyes path warm. We listen for those statements. How do we then figure out, the immediate level of danger? How urgent is it?
That's where assessing the level of risk comes in. Generally, we think about 3 levels. Low risk usually means someone has suicidal thoughts, maybe fleeting ones, but no specific plan or intent to act.
Okay.
Moderate risk involves suicidal thoughts, maybe a vague plan like I might overdose someday, but they haven't stated a clear intent to die right now.
Right.
And then there's high risk. This is the most critical. It means they have a specific plan, they have access to the means like pills or a weapon, and they've stated they intend to end their life.
And in those high-risk situations, time is absolutely critical.
Every second counts. And a really key nursing point from Townsend is never assume someone is safe just because they seem better for a moment. Remember, Carlos.
Right, that sudden calm.
Exactly. Frequent reassessment is vital. And constantly collaborating, talking with the whole healthcare team, doctors, therapists, social workers, that's absolutely essential. You can't manage this alone.
Okay, so let's talk about those nursing interventions. What do nurses actually do when someone is identified as being at risk?
Well, the absolute #1 priority is safety. Always. That means taking immediate steps. Removing potential means of harm from their environment belts, shoelaces, sharp objects, access to medications they'd hoard.
Environmental safety checks.
Definitely. And initiating suicide precautions might be necessary. This could range from frequent checks to one-to-one continuous observation, meaning someone is with the patient constantly. Sometimes a safety contract is used where the patient agrees, usually verbally or in writing, to tell staff if their thoughts worsen before they act.
But it's not just about, removing objects, right? It's also about the human connection.
Oh, fundamentally. Establishing rapport, building that therapeutic alliance is so important. You need to validate their pain, let them know you hear how much they're hurting, but without reinforcing the hopelessness. You don't want to agree that things are hopeless.
That's a fine line to walk.
It is, and developing a safety plan with the patient is key. This is a concrete plan that identifies their personal warning signs, lists coping strategies they can try when feeling overwhelmed, and includes contact information for support people, crisis lines, therapists.
So it empowers them a bit.
Exactly. And as we said, constant collaboration with the whole team is crucial for consistent, comprehensive care.
And I imagine the documentation in these cases has to be spot on.
Oh, absolutely critical. Townsend really stresses this. Precise, thorough documentation. You need to chart specific behaviors you observe, quote, the patient's statements whenever possible, describe their effect, their emotional expression, and list every single intervention you implemented and the patient's response.
Right, like that example of Nurse D's note.
Right.
Patient stated, I feel like I don't matter, maintained flat affect. And just to clarify for anyone listening, flat affect means like no emotional expression.
Pretty much, yeah. A very limited range, a lack of outward emotional response. The note continues. Contracted for safety, no plan disclosed, will continue close monitoring. See? It's concise, objective, but gives a clear picture of the assessment and the immediate plan.
Yeah, very clear. And dealing with this level of risk inevitably brings up some serious legal and ethical issues for nurses.
It absolutely does. Our primary ethical responsibility is the duty to protect the patient from harm. That's paramount. In situations where someone poses a clear, imminent danger to themselves, legal mechanisms like involuntary commitment might be necessary to ensure their safety.
That's a big step.
It is, and it's taken very seriously. Using seclusion or restraints is always a last resort, only justified in extreme emergencies when less restrictive measures have failed and immediate harm is likely. And while confidentiality is vital ethically, we can and must breach it if we believe it's necessary to prevent serious, imminent harm to the patient or others. Safety trumps confidentiality in those specific high-risk moments.
Okay. What about after an attempt has actually happened, and thankfully the person survives? What are the next steps then?
Well, once the immediate medical crisis is managed, a crucial step is debriefing with the client when they're able and ready, trying to gently understand the thoughts, feelings, and events that led up to the attempt.
Okay.
Supporting the family is also incredibly important. They're often traumatized, confused, maybe feeling guilty or angry. Educating them, offering emotional support, helping them understand how to be supportive without being judgmental. That's key.
Yeah.
And then the focus shifts back to reinforcing those protective factors we talked about earlier, rebuilding hope, strengthening connections, and of course, arranging solid outpatient therapy and consistent follow-up care is essential for long-term recovery and reducing the risk of future attempts.
That example of the 17-year-old who survived an overdose really showed the nurse's role in talking with the parents, right? Helping them avoid blame and focus on rebuilding that trust. That feels so crucial.
It absolutely is. The family's response and the strength of that support system can make a huge difference in how well someone recovers.
Okay, finally, the chapter also points out that some specific groups of people might face even higher risks.
Yes, sadly, certain populations do experience increased vulnerability. For instance, older adults often have higher suicide rates, and it can be linked to things like multiple losses, social isolation, chronic physical illness. And it's often underreported in this group. Adolescents face unique pressures. Think social media, bullying, struggles with identity formation. Veterans are another group at higher risk, often dealing with PTSD, chronic pain from injuries, or maybe survivor's guilt.
Right.
And LGBTQ plus individuals, particularly youth, face higher risks, often due to discrimination, stigma, lack of family acceptance, and related mental health challenges.
And for all these different groups, the care needs to be sensitive to their specific experiences, right? Culturally competent and identity affirming.
Absolutely essential. Townsend really emphasizes this. We have to understand and respect each person's unique background, culture, identity, and experiences to provide truly effective and compassionate care. You can't use a one-size-fits-all approach.
Okay, so if we're trying to rack our heads around all of this, it's clear that suicide is incredibly complex. There's no single cause. But really understanding the risk factors, knowing those warning signs like IS path warm, and then applying the right nursing interventions, it really can make a difference.
It absolutely can. Vigilance is key. Clear communication, open communication within the team, collaboration, and always prioritizing patient safety. Those are the cornerstones.
So for you listening right now, especially if you're maybe a nursing student feeling totally swamped by this, maybe cramming for an exam or just trying to process how heavy this topic is, please remember this. You are learning incredibly valuable life-saving skills.
Yeah.
You absolutely can understand this. I know nursing school can feel like trying to, I don't know, drink from a fire hose sometimes. Your brain feels full. But you are building the knowledge, the empathy, the tools to provide care that matters so, so much. Take a deep breath. Remember why you started this journey. And seriously look after yourself too. This work takes a toll. Your own mental health matters just as much. You've got this.
That's so important. And maybe just one final thought to leave you with. Beyond all the acronyms and assessment tools, never underestimate the power of just being truly present with someone, offering genuine, non-judgmental human connection. Sometimes that simple act of empathetic presence, really seeing their pain, is the most powerful intervention of all. It goes beyond textbook and touches the core of compassionate care.